Hey everyone, welcome back. Sean Brewster here and Boating Leading. Topic of discussion today, Bo, is your back is not out. How often have we heard this from patients that walk through the door and go, oh, my back's out, my neck's out, something's out of place?
Far too often.
Too often, right? And to make matters worse, they'll go and see a practitioner and the practitioner will say to them, yeah, your C3 is rotated to the left, L4 is out. We need to put it back in.
Yeah. Reinforces these beliefs of fragility and instability, which is a whole other topic. But that mechanical sort of description around what's going on can be quite alarming to a patient.
100%, and look, above and beyond these psychosocial aspects of it, and we know that that's so important, right? And there's a history in our industry, and when I say our industry, I mean that the manual therapy industry, of this very structural model of care where a bone is in a position that is not ideal, and that's causing pain and dysfunction for the person. And we'll signal out chiropractic as the main profession that has perpetuated that. But I'm not against chiropractors, and I'm not against chiropractic at all. And I know that in more recent years, different models of understanding around that, how the influence of the spine and its position has changed, and it's definitely improved. And we've got a much more evidence-based approach to our understanding now. But some of those still long-held beliefs are still lingering. There's still a lot of practitioners out there that are perpetuating that, aren't they? Their patients coming in, we're doing a scan, we're finding that your T4 is rotated or something, or whatever it might be. And then we are adjusting and adjusting and adjusting and adjusting. And we're looking at the scan again. Has it changed? No, we adjust again. And we're expecting some kind of miracle to happen as a result of those adjustments. It's just not the case.
No, that's right. And, it's not just chiros when you think about different areas in the body that they've got a rotation here and an upslip there and a downslip and a torsion through the pelvis that's leading to X, Y, Z. It's simplistic in its approach to say that is the cause of the pain. When we don't know that at all, and it's probably far too one-dimensional. But often when these types of things are reinforced by practitioners, it can lead down a sort of a cascade of ongoing negative beliefs around someone's symptoms.
Yeah, and it is one of those hard conversations. I find myself having this more and more in an education setting with students around, the idea that a bone can be out of place. I was running one of our joint therapeutics courses on the weekend and talking about this very topic. And when I started to talk about the fact that, bones can be poorly positioned, in relation to where we might ideally like to see them, but it doesn't have to necessarily equal pain. And we don't have to put them back when pain presents. Like, it's not like you're going to push that bone back into place and suddenly the pain goes away. And you see a lot of eyebrows go up and eyes get a little bit wider, and they go, but that's kind of what I've been told. I go and see my osteopath, my physio, my chiropractor, whoever it might be, massage therapist, and we've got to push this back to reduce your pain. But it is an old model of thinking. And I hear a lot of people listening to this going, yeah, but I had something show up on a scan and I went and saw my osteopath and my physio, whoever it might be, and they adjusted that segment in my spine, and now my pain is better. How do we explain that away to those people when there's obviously a bias with that belief, and it's confirmed by the treatment that they had and the results that they got, yet all of the science points in another direction, right?
Yeah, interesting point. You might have different practitioners that might categorize practitioners into what they do. If you've got a muscle problem, you need to see a massage therapist. If you've got a bone or joint problem, you need to see a chiro. Otherwise, you need to see a physio to get things stronger and moving better. So, if someone presents with a disc herniation, let's say, and you need 3 months worth of treatments 3 times a week, and that will put your disc back in. And then they have a follow-up scan. Yeah, well, it has gone back in. Well, there's a high incidence of spontaneous resorption of disc-related injuries within a 3-month period. So was it the treatment, or did it just spontaneously resorb or regress?
Yeah, and it's pretty easy to correlate those two things when they happen by coincidence or by natural progression of healing. And I think that's where this profession has kind of fallen down, is because we've seen this thing over here and we've seen this thing over here, and just assumed that those two things are related, and it's just not always the case. I want to go into some research today and talk about some examples of some of the science that we do know to be true now, or at least the current beliefs. And everything that we, I guess, previously thought was purely a structural driven problem, bone is out of place, therefore pain, therefore dysfunction. We now know that bone can be out of place and have no pain, no dysfunction. So that those two things can coexist, but also that the changes that we get when we do a manipulation or a mobilization at the joint is not about pushing a bone back to where it should be. It's about providing input to the nervous system. It's a neurophysiological change, not a structural change that we're talking about. So I'll give you an example. So I'm just going to read directly from a piece of research that's written by our colleague, Dr. John Serbley, is actually a chiropractor by trade in Canada. And he now is a researcher, and he's done quite a bit of research around this space. So this is coming from someone who would have been taught the very structural model of chiropractic back in the probably 80s, I think, and is now a researcher and understanding things a little bit differently. So it's a direct quote from one of his articles. The article is called Chiropractic Science, a Contemporary Neurophysiological Paradigm. So the evidence suggests that effects of spinal manipulative therapy is primarily neurophysiologic, most likely mediated by intense stimulation of large myelinated fibers in the capsular and or periarticular tissues. Basic science also demonstrates that large fiber stimulation can modulate dorsal horn excitability by inducing segmental inhibitory mechanisms. The phenomenon of dorsal horn excitability, also referred to as central facilitation or sensitization, is pivotal to the contemporary chiropractic paradigm. So what he's proposing there is that we're providing a sensory input at the spine via the structures around the joint. The manipulation is not about moving the bone. It's about providing sensory afferent information back to the central nervous system, and then the central nervous system processes that and makes appropriate changes, pain reduction, improvement in function, and so on.
Yeah, so you mentioned in that paper that the large myelinated fibers. Whereas when we think about that noxious input to the central nervous system, it is often coming from your nociceptors, so your A deltas and your C fibers. So the stimulation of these large myelinated fibers is creating that segmental inhibition, which is reducing the afferent input to the brain. But that manipulation can also create some descending inhibition as well down to that spinal segment at the dorsal horn, which can inhibit the pain.
Absolutely. And so it's less about what's actually happening at the bone and more about information going into the nervous system, which then begs the question, does it matter what we do? Like, do we need to adjust the bone to the left? Does it matter if we apply the force to the right? Does it matter if we're one segment above or below? How important is that if it's just about a somatosensory input that is positive?
Well, that's a great point. It reminds me of a paper on joint mobilization of the shoulder. Anterior shoulder pain, we suspect that an AP glide would help to improve their symptoms, or an anterior to posterior glide. However, in this paper, the PA glide, the opposite direction, actually improves symptoms. So when we think about that from a neurophysiological point of view, well, it's the input to the joint, not necessarily changing the position of it. We're changing the input that decreases the threat to the central nervous system, and that can have an effect on the outcomes or the reduction in pain.
You're right. And when we talk about joint treatment, we typically talk about manipulation or mobilization, and we know that both of those things can have a positive impact. But they're two very different experiences. For the patient, the manipulation is often rhythmic, it's comfortable, it's gentle, it feels good. A manipulation is often abrupt and it's immediate and sometimes almost cathartic. If you've got that really jammed up facet joint, you hear this pop and release, and it's like, now it's better. And so there's a lot of psychosocial stuff that goes with that. So those two types of input, again, I want to read another piece of research that relates to that and maybe challenges even some of the current science around, is it actually just the somatosensory input or is it something else? So this article is called The Role of Spinal Manipulation in Addressing disordered sensory motor integration and altered motor control by Harvick and Murphy. So I'm going to read this one for you. Many of the studies discussed in this paper show that spinal manipulation results in drastic changes in sensory motor integration within the central nervous system in human participants. Collectively, these studies provide evidence to support a central mechanism of action for higher velocity, low amplitude spinal manipulation. So we're talking about manipulation and not mobilization, which is not yet clear to the degree to which these changes correlate with beneficial clinical outcomes. It's also not clear whether these changes are due to the correction of spinal dysfunction, therefore normalizing aberrant afferent input to the central nervous system, or whether they are merely due to afferent barrage associated with manipulative thrust. So it's just that sudden, intense input, afferent input to the central nervous system, or whether it's actually, is it just the sudden insult or input that you get, or is it actually changing something specifically that's reducing the pain or improving the dysfunction? The school's still out on that one, I think, but the fact remains that we're getting an input, and it's not about the bone, it's about the sensory motor input that we're getting.
Well, let's think of it this way. If we've got those large myelinated fibers, right, we've got those proprioceptors, which send very quick information to the central nervous system, as well as in a reflexive arc also. So if someone has altered proprioception or a reduced proprioception due to pain or injury, by stimulating those mechanoreceptors, that could potentially improve the reporting to the central nervous system, right, which can improve the output. All right, so you've got the change in sensory motor drive. So increased awareness, change in input around that area could potentially be a mechanism. What do you think about that?
Yeah, well, this is something I definitely hold to be true. Is patient comes in, stiff, jammed up facet in the spine, whatever it might be, they've got a dysfunction. Maybe it's been identified on X-ray, who knows? They have pain, they have restriction of movement. We mobilize or manipulate that, and they move better. Is it a result of the bone suddenly reducing the gas buildup? Is it that kind of cavitation release? Potentially, yeah, that we definitely feel different after we have that cavitation. Is it the bone moving back into its ideal position? Probably not. Or is it just that we're providing that positive input to the nervous system, and then as a result of that, like you're saying, we get this improved motor function. The muscles around that joint that might have been locking it down, guarding it because of the irritated facet, now get better proprioception, better input from that better efferent information coming out. So they recognize that we don't need to guard this anymore. There's no threat. We can relax. And then through that relaxation, we get better movement. The patient goes, oh, you fixed it. You put it back in. I don't think we put it back in, but we improve the ability for our nervous system to communicate with the muscles that were preventing you from moving and from locking down that facet joint.
Yeah, there's some interesting points there. So you mentioned the release of gas. Think about crack your knuckles. I do this all the time, and they feel a little bit stiff beforehand. You crack the knuckle. I didn't change the joint position or anything like that, but the gas takes up space as well. So the release of that gas potentially gives me the perception that there's now more mobility. You also mentioned that improved reporting. If we've got noxious input, the processing is going to be the output of guarding it, right, and tightening up. Whereas if we change that input to be less threatening, the output could potentially be to be more relaxed. So there's so many different mechanisms at play potentially. It would be too simplistic to say that, well, I did something to a bone, which means it's in place now, which is why it's better.
Yeah, exactly. And this is why that old structural model is outdated now. And it's a hard conversation to have with patients who are ingrained in that model of thinking because they've been taught that by their practitioner. And I imagine it would be an even harder conversation to have with a practitioner who works in that way, in that model, because they see results. Are the results from what they believe, or are they from something else? And more to the point, if it is something else, do we need to treat as often? Do we need to treat in the same way? Could we do it differently? Could we be more effective or more efficient with it? And that's really the benefit diving into this science. It's not to say, no, you're wrong. It's, okay, you're getting results, but maybe there's another way that you hadn't considered. And when you understand that way, maybe you can get better results.
Yeah, and let's look at results, because if a result means 2 days of relief, that's not a result. You know, a result should be something that changes long-term outcomes, not these short-term interventions that need repeated and reliance on a practitioner. Because, yeah, a short-term change is a Band-Aid.
Yeah.
And it's an expensive Band-Aid.
A colleague of mine sent me a chart, and I won't tell you which profession it's from, but there was a chart tracking a patient's progress based on their decisions. And this is a purely marketing technique or tool that this particular practitioner was using, but it made me just scratch my brain and go, how do people get sucked into this? But it was basically showing a graph. And at the bottom of the graph, the patient had decided that they were going to undertake care with this practitioner. And it shows their improvement over time, and it goes up. It's not based on any kind of science. It's just a purely graphical representation of what would happen if you come to see me as a practitioner. Improvement goes up. And then there's a little point that says patient decides to discontinue care with practitioner. Their improvement goes down. What is that even based on? The graph goes on. Patient decides to continue care. It goes up. Patient decides to discontinue care. It goes down. And basically just teaching a patient that as long as you come to see me for treatment, you're going to get better and better and better. But at the same time, it's also teaching them that you need to come to see me for treatment if you want to maintain your health. If you don't, you go down. And that just is setting up our patients for failure.
Yeah, we think about the influence of fear and anxiety associated with that, because if you said, all right, well, we've put it back in for now. It's okay for now, as long as you don't do X, Y, Z. And, you know, you might need this put back in every few days, or you'll need to come and check in to make sure that it's not going to go out. Can you imagine the long-term psychological implications of the fear, the guarding, the protective behavior that's associated with that, as far as fragility and instability, and then, you know, a loss of that self-efficacy? That's the real problem, is, you know, sort of convincing a patient that this is potentially, this could come back at any time. And I think that's the real harm.
Bodies aren't that fragile.
Yeah.
About the way we lived before modern society. Yeah, we probably didn't live as long, but we were getting chased by lions and tigers and bears and things. So, and there was different things. We didn't have medicine around, but, you know, we're not that fragile, and we don't need care to be healthy. We need the right tools. We need the right understanding. We need the right environment. Put all those things together, and every human being should thrive, unless they've got some underlying disease or dysfunction. But this idea that we need treatment, we need manual therapy to maintain health is a flawed one. Let's loop back a little bit and go back to manipulation mobilization for pain specifically. We talked about this efferent output and how it can modify motor control and improve function and range and that kind of thing. The pain's a big one, because pain's the major driving factor behind why most of us would go and see someone like us, right? We'd go and see somebody because pain is present. Yeah, we've lost some function, but it hurts. And so how do we then explain away the fact that when a patient goes in with a stiff, sore neck, painful neck, they get it manipulated, and immediately they go, oh, you know what? That's better. It's freer and the pain is better. How do we explain that away?
Yeah, okay. There's probably a few parts to it, and we couldn't give a simple explanation. But when we think of, again, of that noxious bombardment, or, you know, there's these danger messages from the peripheral nervous system. Let's say it is from a facet joint that's a little bit irritated, right? That area is going to be sensitized. There's going to be a lower threshold of these nociceptors, which means that it's easier to generate a response or a painful stimulus. And then, you know, associated with that, there might be some protective muscle guarding, which again can cause some nociceptive input to the central nervous system. So when we think about, well, why would a manipulation or a mobilization help? Well, it can change the input to that central nervous system. It can potentially address or induce more of a parasympathetic response. okay, which can change the output to settle down some of the noxious afferent messages. There can be endogenous opioids released from the brain, so pain-relieving chemicals that are sent down to that dorsal horn to dampen the threat or dampen these messages that are being sent up. So I think there's a few things involved there, and I don't think that we could just say that it's one thing, because otherwise they should be completely better for the rest of their life after one single session.
That's right. If it was purely a structural thing, we'd push that bone back in place, and it would just be that. That would be the solution. But there's lots of other factors, and you touched on there the endogenous opioid mechanism. So this inhibitory pathway that comes down from the brain. That's such a key thing, and we've all got that built in. And providing the right input to the nervous system, we can encourage that process. We can get more of that effect. And the other obvious thing is the pain gate theory. And so much of the effect of the pain gate relies on positive input to the nervous system. So if you manipulate and it feels good, or if you mobilize and it feels good, we're perpetuating the effect of the gate control theory. We're blocking those pain signals. That's happening at the spinal cord, not the spinal joints. And so manipulation, mobilization moves a bone in some way, changes pressure on the structures around the bone, and it's the input from that. It's not actually the bone going back into place. It can stay exactly where it is, and you can still get the same positive input. I'm going to read you one more bit of research, because I think it ties in nicely to that point, which is this article is called Paradigm Shift in Manual Therapy by Anina Schmid. And she said, the non-segmental nature of hypoalgesia by applying treatment to a more proximal joint rather than the one that is specifically painful. This may be particularly useful in the target tissue if the target joint is inflamed or excessively painful. So what we're saying here is that you can get this reduction in pain, hypoalgesia, by stimulating almost anywhere, but in this case, maybe above the segment that's painful. So in your case, in your example, we had the irritated facet joint. Do we need to manipulate or mobilize that facet? Maybe we don't. Maybe because it's a central mechanism, maybe it's endogenous opioid release from the brain coming down. Maybe if we just go one segment above, we can get still that same neurological reflex coming down to reduce the pain without having to actually touch the thing that's painful, which empowers us to do so much more with those patients that are in a really acute state, presenting with, you can't touch me, I'm too sore. Well, let's try treating you somewhere else.
Yeah, that's an interesting point. And if we look at it, like, I wonder then if you've got say, shoulder mainly innervated by that sort of C5, all right? And then if we think about around the elbow, C6, C7, if you've got an elbow problem, what if changing the input around anywhere in that area that's going to be innervated by the same spinal segment? I don't know, potentially could change that input to at a segmental level. But Sean, what would you say then to someone who they might say, well, yeah, obviously the spinal manipulation isn't going to help if you don't address the muscles, because the muscles are pulling the joint in that position?
Yeah, well, one of the beautiful things about manipulation, and especially mobilization, is that because we provide a positive input, somatosensory input to the nervous system, which then improves the reporting process back to the muscles, we get an automatic normalization of tone or improvement of tone. It might be an increase in tone, it might be a decrease in tone, but because we have better proprioception, our joint is better aware of where it is and what it needs. And so the muscles around that area will automatically, or should automatically, improve their ability to support and mobilize and move that area. And so, yeah, if you just address the joint, you get some overflow into muscle effect. But in the same way, the opposite is true. You can provide positive input to the muscles and get an effect on those proprioceptors in and around the joint structure. So both support each.
So what would you say to the model of, the massage therapist is in there loosening up the area for the chiropractor to come and make the adjustment? What do you think about that?
Well, I don't know if you can hear in the background, but my baby's crying, and I think she's upset with that question. So the idea that we need massage to then be able to manipulate, look, it helps. in one way and it hurts in another. It helps if you have a patient who is going to benefit from some manipulation or mobilization, and you could do some soft tissue work first. Maybe the manipulation is easier, but is the manipulation the thing that makes the difference? We don't know. But the other side of that problem is that it's setting up the person doing the adjusting as being God. They are the person who holds the key component to the outcome. The massage is the setup, and then God comes in and waves his magic wand, her magic wand, and the effect is apparent. Those two things can coexist, or those two things can exist separately. It almost doesn't matter, providing we're having a positive input to the nervous system. You can have an effect on both.
But I think it's also setting the patient up under the impression of a very mechanical framework. It's sort of like, this is leading up to the main event. All right. And the main event's what we're here for. And everything else is just sort of the pre-show, and it's not that exciting. So it's not until that they get me ready, they get me amped up enough for the main event that's what's going to put it in, and that's what's going to solve all my problems. So yeah, I think the perception and the influence of that is key, and how that may be detrimental long term when that doesn't change their symptoms and they get increasingly frustrated and they go, well, I saw the best chiro or best whoever, and they did everything in the lead up, but my symptoms didn't go away. That's the real challenge, and really
or in the same way that you set them up for that manipulation and it doesn't pop like the way you wanted it to, and so then the practitioner displays their disappointment. You feel disappointed, you feel like nothing's happened. But if the force was appropriate and it was comfortable and provided an appropriate input to the nervous system, the effect can be just as great, if not better sometimes. That's why mobilization compared to manipulation, often those two things are compared as two separate things, but they both have the potential to produce the same outcomes.
And also that, I guess, let's say you're just doing some broad compressions on a patient and get a few pops and clicks. Oh, wow, that was awesome. So the influence of what that means to them as well can create more of a release of those endogenous opioids and that endorphin and enkephalin response, which is feel good. When these feel good hormones are released, they can decrease the pain as well. And it may not be that it's a specific manipulation, mobilization, or adjustment that is actually causing the relief from symptoms.
Absolutely. So I guess the summary of all this is that, when we talk about joints, it's easy to think about them from a purely structural perspective. There's a bone next to another bone, and they're not as aligned as they should be. And if we can align them, well, then, everything gets better. And that is such an old way of thinking. And I think hopefully what we've done here is explain that there's a bit more to it than that. And that the realignment of those bones is probably the least important component of it, if not completely irrelevant. It's more about doing a technique, and whether that's mobilization, manipulation, dry needling, massage, stretching, just patting them on the head and telling them a nice story, whatever it is, if you can provide a positive input to the nervous system, those already built-in pain modulating mechanisms will come into play. The already built-in sensory motor mechanism, which helps to support and facilitate better function and movement and coordination, will come into play. The body finds its homeostasis. That's the meaning of the word. It will find its balance. It will come back into that state of being that it is designed to be in. It's just about providing an appropriate input, and there's 1,000 ways to do that.
Yeah, definitely. That's right.
All right. Have we covered it all?
Oh, there's probably a bit more, but
probably a bit more
for today.
And look, I have a feeling this is going to be one of those ones where we're going to get some follow-up questions and comments, and 100% encourage people to do that. So if you don't agree with anything we've said here and you think there's another perspective, please let us know. If you do agree, please let us know that as well. We just love the feedback. So I'm happy to answer any questions or have a conversation with anyone around this topic. So thanks for tuning in, guys.
Cheers.